Welcome, Dr. Farmer. As
you.
it says here, she's the director of the Movement Disorder Program at GNI. And anything else you want to tell us about yourself and your practice and a little bit about your background before we get started on your slides?
Sure. Well, thanks everybody. I am seeing the numbers climb for participants, and I think that is amazing. That just kind of goes to show how we are adaptable people and that we can make things work, whether it's virtually or face-to-face. And I know that you guys have been doing these lunch or breakfast with docs even before the pandemic started, so you had a leg up on how to navigate this technology. And I think this is a great resource. I am a movement disorder specialist. I have been out of fellowship for close to 10 years, and I practice primarily in the New Jersey and Bucks County, North Philly region. I've been seeing most of my patients through telemedicine through this time, which is something that you should all be aware of, that it is possible with telemedicine now, while the restrictions have been listed, to see specialists from all across the country because you are not restricted by geography anymore. You can see patients across state lines with the telemedicine that's in place. So something that may be a benefit if you had been looking to either see a movement disorder specialist and there wasn't one in your area, or if you are looking for additional opinions and things like that. So trying to make lemons out of lemonade, it is something now that it is possible for you to do. And movement disorders lends itself very well to the telemedicine platform. And with that, we can get started if that's okay with you guys. Yep, okay. So they asked me to speak today about cognition and Parkinson's disease. And this is a presentation that I've given a few times for different audiences. Grand rounds at an academic institution, support groups and patient ed programs. So if you have seen the slides beforehand, I did share them, I don't know if you have them, don't be off-put by some of the science and some of the loops and all of that stuff. I put that in there because Parkinson's patients are an educated bunch and they like to know a lot about a lot. And I want to give you some of the background as to why you might be having some of these symptoms, but it will not be boring and I'll try to keep it extremely practical for you. So I have no disclosures that are pertinent to this talk. This is a slide that I put in on a number of my talks because it gives a visual of just how complicated the dopamine pathways are. We try and simplify it and just say that dopamine, the Parkinson's is related to dopamine and it's related to movement, and that's kind of the boilerplate version in a nutshell. And anybody that lives with PD or cares for people with PD knows that that does it a disservice to try to simplify it to that regard. And dopamine is involved in a lot. It's involved in a lot of movement. It's involved in a lot of non-motor symptoms. It's involved in things outside of the brain, like the gut and sensation and pain. And so dopamine is more than just something that's lacking that causes you to have a tremor or be slow or be stiff. So in today's discussion, we'll kind of do a brief overview, discuss the non-motor symptoms, in particular cognition, and try to tease out some of the different flavors of cognitive concerns that are part of Parkinson's, and hopefully offer a little bit of reassurance that not everyone with cognitive concerns in Parkinson's progresses on to Parkinson's disease dementia. So the main criteria for Parkinson's disease comes from the motor symptoms: tremor, slowness, that's bradykinesia, rigidity, stiffness, loss of postural response or your balance issues. So when your doctor pulls you back like this, we're checking to see if you can catch yourself. Fixed posture, that's stiffness and freezing. There are academic distinctions. Is it definite? Is it probable? Is it possible? But any neurologist, family practitioner, general practitioner, movement disorder specialist worth their salt can really pick out a Parkinson's patient on their motor symptoms based on just observing them before them. The decreased arm swing, the stiffness, the slowness, whether they have tremor or not is helpful but not always necessary, because about 30% of patients with Parkinson's won't have tremor. And so you can pick that out. The motor symptoms are are not to say that they're easy, but they are distinguishable. Then you get into the non-motor symptoms of Parkinson's disease, and that's where it becomes a little bit more complicated. So if you were wondering where all of this dopamine lived in your body, on the left side of the slide, you have those little Mickey Mouse ears, and there's a big black line. That's called the substantia nigra, or the black substance. And that is the neurons that make the chemical dopamine. That's why when you read the side effect profiles of your meds, and I really hope you don't, but if you do, and it talks about an increased concern or risk of melanoma in patients with Parkinson's disease, it's because that black substance has melanin in it. And there is some relationship, and we don't know what that is, between melanin and dopamine, dopaminergic neurons. So if you are someone that lives in the Sun Belt or anywhere that's sunny and you do spend a lot of time outside, it is good practice to get a yearly skin check, whether you have Parkinson's or not, but especially if you do, to just take a look and check those darker spots on your skin to make sure that there's nothing abnormal about them. As Parkinson's progresses, you see that black line goes away, and that really is the pictorial depiction of a loss of the dopamine neurons. And on the right side of the slide, that little round bullseye, that little egg-like inclusion, that's that abnormal protein. Those are what, when you can hear Lewy bodies or abnormal inclusions of alpha-synuclein and stuff like that, that is the inclusion that kills off the dopamine neurons. So that's what's happening on a pathologic level. The non-motor symptoms reside in those areas too. So those little black dots that project up from that black line in those Mickey Mouse ears of the midbrain target motor centers of the brain, and they target non-motor centers of the brain. So things like sleep disorders, your sense of smell or olfactory disorders, things that happen automatically, that temperature regulation, bowel functions like constipation, impulsivity or your emotional regulation. All of these things are impacted because of the loss of that dopamine, in particular cognitive function, which is what we'll talk about today. So some of my patients who may be on this call will often hear me say that if you're low in one chemical, you're low in a lot of chemicals because they're part of the same pathways. And that's why you have different symptoms. So as you can see, things like serotonin, dopamine, norepinephrine or epinephrine, and that is your adrenaline, your flight and your fright. If you are low in dopamine, then you're going to have an impact on how well norepinephrine functions. If you're low in the creation of dopamine, you're going to have an impact on the pathway that makes serotonin. Serotonin helps with your mood. Norepinephrine helps with your energy and your vim and vigor, your drive to go and do something. So that's why when you're dealing with a loss of dopamine, you have these other non-motor symptoms that are impactful. And that's why polypharmacy in Parkinson's is sometimes helpful, because we try to get to the symptoms by the chemical that is most impactful for them. So you might be on medicines that regulate dopamine, you might be on regulants that regulate serotonin and norepinephrine. And those fall under the antidepressant or anti-anxiety medications category. But that's not because it's a primary depression or a primary anxiety. There's a chemical reason in relation to your Parkinson's of why you're experiencing some of these symptoms. So in Parkinson's and cognition, there's a spectrum, like we said, from mild cognitive impairment to Parkinson's disease dementia. There is diagnostic criteria that can be used. So mostly that's used for study purposes, so that you try to get a very cohesive patient population to make sure you're studying the right thing. Clinically speaking, it's a little bit more, it's a little bit looser in the diagnostic criteria, but there is an FDA-approved treatment, and some of you may recognize this. This is the Exelon patch. While we borrow a lot of medicines from our counterpart in the Alzheimer's world, this is not Alzheimer's. It's a different pathology. It's a different form of cognitive impairment. But we, as with many things in neurology, we beg, borrow, and steal from our neighbors. So a lot of what we have to use to treat the memory symptoms in Parkinson's comes from the Alzheimer's silo. But there is something that is specific, and it is the Exelon patch. Exelon pill is sometimes substituted, but preferably we like the patch because of its slow delivery system and the ease of use because it's just once a day. So this is, like I said, is the diagnostic criteria. Our governing body, if you will, as movement disorders is the Movement Disorder Society, and they come out with practice guidelines. And this is what the guidelines show. Basically, you have to have a diagnosis of Parkinson's disease. There has to be gradual decline in the context of Parkinson's disease. You have to have cognitive deficits on either formal neuropsychological testing or a scale that is done in the office. We'll talk about these in a little bit. Formal neuropsychological testing is a battery of tests that takes hours. There are quicker scales and screens that can be done by your doctor during the office visit, asking you to draw a clock, asking you to recall certain words, asking you to draw different pictures of intersecting diagrams or pentagrams or boxes or things like that. So there are some quantitative strategies to sort of scale where you fall on the spectrum of cognitive impairment that you're having. And then the guidelines for mild cognitive impairment come in an abbreviated assessment and a comprehensive assessment. And that's basically what I was just talking about. An abbreviated assessment is looking at those screening criteria that we do in the office, the mini mental status exam, the MMSE, the mini cog, which is just asking to draw a clock and recall 3 words, or the MoCA, the Montreal Cognitive Assessment, which looks at the different domains of cognition from visual spatial to recall to semantics and fluency of vocabulary and calculations and things like that. And they don't take very long to complete. Sometimes they're not done as formally as bringing the paper to the patient, but the doctor is doing them in their head because they're just used to looking and teasing out the types of questions that need to be asked for cognitive concerns. And that is important because there is another patient advocacy organization called the Parkinson's Alliance that does wonderful surveys, and they look to the Parkinson's patients from around the country to submit surveys. And one of the surveys they did in 2016 was on cognition. And they, as a movement disorder specialist, I know how important cognition is to my patients. And I have heard the concern for cognitive problems. And I do my assessments, but that doesn't necessarily translate to patients feeling like they're getting an assessment for cognition, which was interesting because I do a lot of these things all the time, but I don't often frame it or bridge it with, this is a test of your cognitive concerns. So many patients felt that this was a symptom that was not recognized by their doctors, movement disorder specialists included. So that is a good lesson for me as a doctor to make sure that I'm always letting my patients know the purpose of the questions I'm asking or the physical exam that I'm doing. Because even though it might seem like it's conversational and casual, there's something calculated behind it on my end. And then the comprehensive assessment is essentially the same thing in the office, but with the added component of the formal neuropsychological testing that's done by a neuropsychologist. So this is an example of the MoCA. Some of you may have seen this, some of you may have done this. It's available online, not that you should practice and do it before you go to your exams, but it's available and it's free. And I like this because it shows you all the different things that go into thought. Visual spatial, you know, being able to manipulate objects and follow a particular pattern or task. Naming, that's your verbal fluency. When I have it on the tip of my tongue, doc, but I just can't get it out. Memory is recall, so giving you words to remember and then asking you for it, being able to repeat them back to me in an immediate recall and then asking you for them later in the course of the test. Attention is being able to focus on a particular task at hand. So if I give you numbers to remember, can you repeat those numbers back to me? But now can you repeat those numbers backwards? It's a little bit more difficult, but you had to pay attention to the sequence beforehand in order to do the second. Are you able to calculate? So serial sevens, can you subtract a number from 100 repetitive times and get it correctly. If I ask you to pay attention to a particular letter that I'm saying in a string, and you tap your knee when you do that letter, do you only do it one time like you're supposed to? Or do you perseverate, which means do you keep doing that action over and over again? So instead of just tapping once when you hear the A, you tap 3 or 4 times. These are all indications that something in the network of cognitive processing is being impacted by your Parkinson's. And then there's a longer test. This test is called the Scopacog. Most people have not done this unless they are part of a research study. The mini mental status, the MoCA test and this test have the same, what we would call sensitivity and specificity when it comes to testing, in the high 90s to be able to indicate that there is a cognitive issue or a concern. This test is much longer to administer, and it's a more difficult test, in my opinion, of the types of questions that they ask. But just in case some of you were wondering, or if you've experienced this test, it tests the same 7 domains of cognition that the MoCA does on just a longer scale. And then maybe none of you have done any of these tests, and you're thinking, but has my doctor checked or taken into account my concerns for cognition? Oftentimes, just because of the nature of timing and frequency of visits and things like that, we'll do something called the mini-cog. And the mini-cog is just asking someone to draw a clock and tell a particular time, and then do the recall of 3 words. So giving the patient 3 words and then having them say those 3 words back to them quickly, and then again later on in the course. And that is the quickest test to administer, and has a sensitivity and specificity in the 80s. So for something that is very short to administer with a good return on being able to pick up some issues or concerns, that's usually the one that's done the most frequently in patient visits. So for the neuropsych testing part of it, if any of you have gone through this, you will recognize some of these as we talk about them, even if you didn't know that this is what they were called. But there are tests called the Stroop word color test. There's the Wisconsin card sorting test, and there's different ways of testing memory and visual spatial function through different patterns and blocks and rearrangements and things like that. So I'll take a look at some of these. So this is sort of what they look like. The easiest one to sort of do on your own, if you were curious, because you don't need anything other than pen, paper, and different color, excuse me, markers, is the Stroop test. And what this is a test of attention and focus. So if we were to ask you, looking at these words, don't tell me the word that you read, but tell me the color that the word is. It's really quite difficult. These tests are not easy. I often say that I should put myself through a neuropsych battery just so that I can have a better understanding of what I'm asking my patients to do. I'm a little concerned to do that because who knows what they will find. But it's like going through an MRI. You have to experience an MRI before you can explain to a patient how loud and how claustrophobic it can be so that you can let them know what's coming. These tests are hard and they're not easy. And trying to do that just now, instead of saying the word red, if you said orange, green for yellow, and red for green, you can see how it's meant to sort of give you pause and not trip you up, but really test the circuitry that they're looking for cognition. So the idea of motor and non-motor symptoms, how it relates in Parkinson's disease, I use this example a lot when I'm explaining it to my patients. There's a correlate. So if you have bradykinesia, which is slowness of movement, you have bradyphrenia, which is slowness of thought. If you are rigid in your motor symptoms, then you have a cognitive inflexibility, which means that you don't adapt or adjust to new information or new situations as easily as possible. If you have stuttering in your gait, that's an example of perseveration of your thought, kind of that I'm picking up on things, picking up on things, picking up on things, and I can't get past what it is that I'm trying to do. And there is a reason for this, that in the area of the brain where you lose that black line that we saw in that very first slide, real estate is important. So there's a front and a back, or a dorsal and a ventral part of that midbrain area. And it's so small, it's hard to imagine that a couple of millimeters one way versus a couple of millimeters in another way has an impact, but it does. Because in the area of in the dorsal area, or the area that's closer to the front, if you have loss in those areas, that's where most of your motor symptoms lie. If you have loss a little bit further back, in the ventral area, those projections are slightly different, and those go to the areas of the brain that impact cognition and emotion and things like that, and you can have more of the non-motor symptoms, which is why we say, if you've seen one patient with Parkinson's, you've seen one patient with Parkinson's, because there are so many variability, there is so much variability to the clinical presentations that patients can have because of simple things like this. Are you having a little bit more of your loss closer to the front of the midbrain, or a little bit more of your loss closer to the back of the midbrain? And there is no way to know, because there is nothing that we have that is that sensitive to be able to test to that degree. So this is something that drives docs batty in training. There are 5 loops to the brain. This is something that we're not going to delve into, but just to give you an idea that everything really truly is connected, because one part of the brain does not act in isolation to another. And there's the motor loop, the one that controls the movement. There's the orbital frontal loop. There's the anterior cingulate loop. Those loops are, the anterior cingulate is, we could have called that the emotion loop. The lateral orbital loop, we could have called the visual spatial loop. But the dorsolateral prefrontal loop, that is the loop that impacts cognition. And while those are, medical terms, if you put your hands on the sides of your head like this, that gives you the idea that the lateral, meaning the outside, the dorsal, meaning the top, prefrontal is right here. So that gets that big part of the brain called the frontal lobe, which is the part of the brain that is most impacted in executive function. The executive function is your planning, your, doing higher levels of thought processes, your calculations, your motor planning, your planning for your cognitive planning. And because the lateral is somewhat involved as well, that's sensory and emotion. But mostly it's this part of the brain right here that's being impacted. And that's because, we'll see in another slide, the projections from the midbrain that you can see, you hear the midbrain right here and the substantia nigra, that black substance that has the dopamine neurons in it, project right up to that front side of the brain. So there is a anatomical and pathological reason why you are experiencing the cognitive symptoms that you're experiencing. This goes to show you sort of the progression of, remember those little egg-shaped things that I showed you in the second or third slide, those Lewy bodies? Those are the things that gunk up the system, that get included into the neurons and kill them off. It starts in that midbrain area, and then it traces the projections of where that dopamine would go up into the higher levels of the brain, which is why some of the earlier symptoms for Parkinson's disease have nothing to do with motor at all, but can be loss of sense of smell or sleep disturbances. So if you look at that very first brain on the left, in the brain stem, in that midbrain area just underneath, that is where your sleep centers are. And those are impacted, which is why patients can have REM behavioral sleep disorder for decades before they're ever diagnosed with Parkinson's symptoms. And then you can see that just underneath the first outpouching of the brain, that's the olfactory bulb, that's your sense of smell. Those are the nerves that help with sense of smell, which is why loss of sense of smell is something that's asked about, as it can be an early determination that you may be developing some dopaminergic dysregulation. And this is a slide that just kind of shows you the combination of how our meds work and how they are impactful for motor and non-motor symptoms. So you might recognize some of the names on this slide: entacapone, which is Comtan, or selegiline and rasagiline, which are Eldepril and Azilect. L-Dopa is levodopa. So you can see where some of these work and why we use more than one. Because when we're dealing with medications for Parkinson's disease, dopamine is the gold standard, levodopa is the gold standard, but how do you enhance the effect of that dopamine? Can you prevent it from being broken down? And that's where the chemicals, the MAOB and the COMT come into play. So those chemicals that break down dopamine, if we can stop breaking down the dopamine, it allows it to be used more effectively. So that's why you have Comtan, because that prevents the breakdown of COMT, or rasagiline or selegiline or sulfonamide, which is Xadago. Those prevent the breakdowns of MAO and MAOB in particular. So if you can get those to work in consort with one another so that you can get that L-Dopa down that nerve terminal to the end so that it can work its magic downstream, that is helping you to enhance the effect of what dopamine should do. So it's helping you to enhance the motor effect as well as the non-motor effect. The problem is all of these medicines have indications for the motor symptoms of Parkinson's disease because that's how the studies were done. So we don't have anything that we can say helps with cognition or the non-motor symptoms because that technically isn't how it was studied. But clinically speaking, and evidence that we have seen in our patient populations, we know that when dopamine is optimally managed, both the motor and the non-motor symptoms are improved. And this is the relationship between, if we were getting a little bit more technical, there's different receptors of the brain that impact dopamine. There's about 5 or 6 of them. And there is a relationship between how the dopamine, which one of those receptors has the most impact on cognition. And the jury is still out on which one of those that might be. But there is a reason why sometimes when patients are given carbidopa, levodopa, or a dopamine agonist like Mirapex, pramipexole, Requip, ropinirol, Nupro, the patch, rotigagine, why sometimes they feel so, on that they're clear and they're focused. And then other patients, when they get those same medications, feel like they are walking around in a fog. It makes our lives difficult as prescribers. It makes your life difficult as patients because the reaction to patients across the board is not 100% consistent. But instead of there being a seesaw relationship between the two, it's more like a U-shaped relationship where some patients it has a benefit and some patient it has a negative impact. And the only way to really know is if trying the medication and see how well you respond. So how do we get to be more specific so that we know that if we're prescribing something for patients, it'll have the positive response instead of the negative response? And that is an active area of research. So oftentimes I get asked the question by patients, how can I be involved in research? How is it something that that I can do to not only support the greater good, but also support and improve the symptoms that I'm experiencing? And if you're looking for, not too in-depth time-wise types of research, then I would look to the national biomarker studies. And you can find these studies on Fox Trial Finder or why am I blanking on the site? Oh, clinicaltrials.gov. And these usually just require a buccal swab. Sometimes they require a blood sample. Sometimes if they're more in-depth, they'll require spinal fluid, but that's a different story. But some of the more general ones, you can get away with just mailing something back in, and they're looking for these biomarkers that are known to have an impact on cognition in Parkinson's disease to be able to see if they can find a trend, or they can look at if patients' different responses to medications based on the biomarkers that they might have in their own body systems. So these are also borrowed from studies in the Alzheimer's research. So like I said, we beg, borrow, and steal from each other all the time. but that it's an active area of research of what they're looking at. Nothing necessarily that translates into clinical improvement just yet. But when I mentioned earlier on in the beginning of my talk, not everybody with Parkinson's disease progresses to Parkinson's disease dementia, it's because of this enzyme, the COMT genotype, which, if you recall, is the same enzyme that we manipulate in some way with our medications to help let levodopa persist a bit longer in the system to be used more effectively. It turns out that some patients have a particular type of COMT enzyme, which will allow them to experience mild cognitive impairment, but not progress on to Parkinson's disease dementia. We don't know who these patients are. We don't know how to tease them out clinically, but it is a true phenomenon that has been well studied and documented. So that's why we feel comfortable saying that not everybody that experiences mild cognitive impairment in Parkinson's disease will go on to progress to Parkinson's disease dementia. But many patients will experience mild cognitive impairment. On the orders of over 70 to 80% will say that they are experiencing something. Those that do progress on to Parkinson's disease dementia, because of as good as we try to be with those diagnostic criteria that we laid out in the beginning of the talk, it's still a very subjective symptom to discuss, especially if neuropsychological testing is not on board. So the range of progression varies from 30 up to 70 or 80%. So it likely falls realistically somewhere in the middle of that. So people will progress on to Parkinson's disease dementia, but they themselves will also not have that same type of memory issues or decline that someone with Alzheimer's has, because Parkinson's dementia doesn't affect the same type of amnestic qualities that Alzheimer's does. It's more of a difficulty with multitasking, difficulty with word finding difficulties and stuff like that, which is the type of dementia that can have therapies applied to it and can be worked through with some degree of improvement or maintainment of stability. So as we were talking about, there is no FDA-approved treatment for mild cognitive impairment in Parkinson's disease. They looked at the use of rasagiline. It never ended up getting its indication, though it did have some nice anecdotal evidence behind it. But we do know that there are a lot of things that do impact cognition. So I end on this slide because, again, it tries to reiterate the importance of not just polypharmacy, but multiple areas of intervention when it comes to things like cognition. If we're not just dealing with dopamine, but we're looking to serotonin, if you have anxiety or impulsivity or compulsivity, that is impacting your thought pathways. So that needs to be managed and modulated in some way. So if the anxiety is lessened, then your thought process will improve. Your level of alertness, energy, concentration, that's norepinephrine. If you have no boost to do anything, likewise, what can come into this into the green circle is sleep. If you are not sleeping well, if you have sleep apnea that's not being treated, if you have sleep fragmentation from Parkinson's or from other things, if you are not getting good restorative sleep, then that's going to impact your mood, and that's going to impact your level of alertness, and that's going to impact your cognitive function. So addressing cognition is not simply slapping on the Exelon patch. There's a lot of other things that can go into this as well. So in my patients, I often say, what can help with mood? What can help with movement? What can help with emotional regulation? And that's exercise. Exercise improves serotonin levels, exercise improves norepinephrine levels, exercise improves dopamine levels, and hopefully it'll keep you on a good sleep cycle, because if you're active during the day, you're not oversleeping, you're not being terribly sedentary, and you'll have better sleep at night. The other thing that is helpful aside from medications is therapy. So physical therapy, because we know exercise is helpful for cognition, but also cognitive therapy. Cognitive therapy is something that is often overlooked, and I'm guilty of this myself. I do not refer for cognitive therapy enough. But in that survey study that was done by the Parkinson's Alliance that I talked about a little earlier, they found that wherever patients fell on the spectrum from mild cognitive impairment to more severe cognitive involvement, cognitive therapy was helpful. It's not behavioral therapy, so it's not through CBT, but this is the type of cognitive therapy that is done with a speech therapist or a cognitive therapist in particular. Cognitive therapists can sometimes be hard to come by, but speech therapists are often much more readily available, and their type, they can be referred to specific for cognitive teaching and cognitive strategies. So that's something that I need to remind myself of as a provider sending referrals, but also to let patients know that it's something that they can ask for because it has been shown to be quite helpful and quite beneficial. And I think that is it for my slides, and we can open up the rest of the time for questions and answers, if that helps.
Excellent, thank you. I'm going to turn off the screen share so that we can all see each other's wonderful faces. We purposefully choose this version of Zoom, so you know we're not in the same room as each other, but it's nice to see all the faces. So I'm gonna two people asked about facial recognition. And let me scroll up and find it. Okay, so Susan from Cincinnati. Hi, Susan. She's saying that she's having difficulty with facial recognition when she sees someone out of context and wondering if that's a symptom of Parkinson's. She's better at recognizing voices and wondering if there's anything to do to increase recognition skills. So I don't know if she means like, you know, I don't know, flashcards or Sudoku, or, but that's a good question in general. Like, you know, you mentioned exercise. What else can people do?
So facial recognition, it can fall under that attention and focus piece of cognition. It is something that, because especially when it's out of context related, there's a lot that goes into that split second of being able to recognize someone. You have to place them in a context. You have to remember why you would remember their face in the first place. And you have to be able to pay attention to the surroundings around you. So facial recognition is a pretty complex thing. And so yes, it is something that can be impacted by cognitive concerns in Parkinson's disease. As with many of the cognitive concerns, the strategy is similar. And the first part of the strategy, same thing with word finding difficulties or things like that, don't put yourself on the spot. So if you recognize that you are having difficulty placing this person's face, give yourself a moment, count maybe if you can, like in your head to 5 or 10, but don't try to force yourself to remember because that sort of grinds everything to a halt. Thought agility is a bit of a skill that can be helped, and that's where the cognitive therapy comes into play. So if you can, if you do have the ability to look to a speech therapist or a cognitive therapist to work on that ability for recall and recognition, that would be good. You can also, as you were saying with flashcards and stuff, do that sort of thing on your own. It's slightly different, a flashcard, than it is a face recognition, but there are flashcards with faces, and better than that, if you had pictures, I mean, who has printed out pictures anymore? But if you do, if you just did it with the pictures of the people that you know and that you recognize, to kind of train yourself to being able to recognize their faces. But the first and foremost thing is when you realize that you're having a cognitive slip, don't put yourself on the spot. Take a few seconds, count to 10, do a couple of deep breaths, a couple of deep breathings, and you'll find that a lot of times it sort of works itself out.
Okay, very good. And so Susan asked me to ask you her question, and I have another in the queue, but also for those of you who want to ask your question live on camera, we want this to be as interactive as possible. So just give us a little wave and we will unmute you, and you'll be able to ask your question directly to Dr. Farmer. And I have my two colleagues who are out here monitoring, so we'll keep our eyes out for anyone waving with a question. I will go next to a written question, and then I see Raya. I'm probably mispronouncing that, but then we'll go to your question next, Raya. So Lynn wanted to know about stress impacting PD thinking, which I think tied into what you mentioned about putting yourself on the spot. So could you speak about that?
So stress impacts everything for Parkinson's disease. Again, if any of my patients are on, they will know that I often say you cannot disentangle mood and motor symptoms. It's just impossible to do. So the stress will slow everything down. It can bring a tremor back. It can make your gait off. It can cause you to shuffle. It can make you feel more stiff. It can slow down your thought processing. And again, that same strategy as before. If you can recognize it, sometimes that takes the stress off a little bit. And if you can allow yourself, and it's so hard to do, and I'm not saying it flippantly, like, oh, just give a couple of deep breaths and it'll pass. I know it's an exercise in behavior change in order to do this, but if you can recognize that the stress is impacting and you're in a situation where you have the ability to be able to give yourself a little extra time, step away from whatever situation it is, remove yourself from whatever stimulus is causing the stress, and then come back to it, oftentimes it does work itself out. Now, if you are having a lot of difficulty with being able to behaviorally manage stress, and it's not something that's just because I'm in a room full of people that I'm all of a sudden I feel put on the spot, but it's I wake up in the morning and I'm already tense and I already feel like I have a heightened anxiety of things, but you might not realize it's anxiety. Those are the conversations to have with your doctor, because those are the things that are really common in Parkinson's, and that's where, if not just behavioral strategies, but medication adjustments come into play.
Okay, and one last stress-related wrinkle. Danielle said, and this is very insightful, she can identify that her reaction to sudden stressful situations that cause an adrenal rush is very exaggerated. Mm-hmm. Is that something related to what you've been talking about?
Yeah. Mm-hmm.
Okay. You know yourself well, Danielle. Okay, so my friend Raya, I'm going to unmute you, or actually you need to unmute yourself. We're both pressing on the same button there. Okay, hi, did I mispronounce your name? Is it Raya?
No, you didn't miss it. It's okay, that's my name.
How can, what's your question?
Hi, well, Dr. Farmer is my doctor, so hi, Dr. Farmer.
Hello.
I'm going to see her in a week, but before that, I mean, she knows, but I'm struggling lately. Haven't seen her for a few months. It's more and more debilitating. It's that fatigue. Mm-hmm. That I'm dealing with every single day. It's like from the morning till the night, all the time. When I exercise, I used to exercise much better and much more, and now I can hardly exercise. I don't know what it is. Why the DBS, and I don't know why.
Yeah. No, so fatigue in Parkinson's is not an uncommon concern, and it is multifactorial. It's part of that low level of epinephrine, that flight and fright kind of thing, that vim, that vigor that gets you up to go. It's mood related, it's poor sleep related, it's the cycle of not being able to exercise as well, and then that sort of also increases the fatigue, even though you would think that you'd be able to rest more and you would have less fatigue. It's really difficult to manage, and we try to manage it. We have nothing specific for it in Parkinson's disease to manage fatigue. What we do is we would manage it the way we would tell anybody else to manage fatigue, regardless of the underlying symptoms. Increase caffeine intake or a stimulant intake to some degree, take scheduled naps if we could, hydration, hydration, hydration. And then if we need to look into medications, we can, not just adjusting the Parkinson's meds. Some Parkinson's meds are notorious for causing fatigue, like dopamine agonists at higher doses and stuff like that. Levodopa itself, if you're taking high doses, can cause a fatigue at its peak effect and then sort of wears off. But then sometimes we look to meds that can help be more stimulating. Meds that are borrowed from the sleep apnea world, meds that are borrowed from the cognitive world, like Ritalins and things like that. And also medications that can just help with not necessarily the cognitive aspects of fatigue, but have been shown to help fatigue in other neurological conditions like MS, called naloxone, or naltrexone, I'm sorry. They are, these are medications that, again, are borrowed from other things, but if we've tried all the first line strategies of behavior and med adjustments, then bringing on board something secondarily might be helpful.
Okay, very good. And like, I love your slide with the Venn diagram that, you know, that it's all connected. You know, if you're not sleeping and you're tired, or you're napping and then you don't sleep at night, then that it can just affect everything.
Yes.
So next up we have Norma Murphy. Norma, if you want to go ahead. And thank you, Raya, for your great question. I think a lot of us, we've been hearing that, a lot of us are feeling that too. But go ahead, Norma, what's your question?
I have bad sleep fragmentation in that when I get up in the middle of the night to go to the bathroom, I am fully wired and wide awake at that point and can't go back to sleep. My neurologist, who is a movement disorder specialist, has me on 50/200 of carbidopa, levodopa right at bedtime to try and help my dopamine levels stay up. The psychiatrist who does my medication management for anxiety and depression has me on 6 milligrams of Lunesta at bedtime as well. I have no issues going to sleep. That's very quick, within 5 minutes. But I just can't get back to sleep again. And my neurologist does not recommend napping during the day. I am exercising at least 3 times a week, 4 times a week with Delay the Disease or other classes. I'm not sure what you might have to recommend.
Sure. So sleep fragmentation, again, not uncommon in Parkinson's disease. I tend not to use sleep aids, things like Lunesta or Ambien or Balsamra or things like that. I find that Klonopin works well for patients with sleep fragmentation. Now, Klonopin is a benzodiazepine. As a movement disorder specialist, we use them frequently and we use them at low doses, but it is a class of medicine that sometimes make people pause. So it's something that you kind of have to see the comfort level of the doctors that you're seeing, what they would do. Typically, it is the treatment of choice for REM behavioral sleep disorder. Even if patients do not have REM behavioral sleep disorder, in Parkinson's disease, that's when people act out their dreams, very vivid, yell, kick, scream, that sort of stuff. But I also have found it helpful for sleep fragmentation. The other thing is, if you are not having difficulty falling asleep but staying asleep, if you are waking up consistently at around the same time each night, it could be because your carbidopa levodopa is wearing off. So you could look to one that's even slightly longer acting, like a Rytary dose at a 245 milligram, and just take that at bedtime. Or when you wake up, you can take a carbidopa levodopa and see if that helps you fall back asleep at that time, either by chewing it or crushing it or something so it gets in the system more easily. The other would be, I just lost my train of thought as far as, see, it happens to us all. There was something else along the lines of, melatonin. If you are looking, melatonin in and of itself, people can poo-poo because they think that it's an over-the-counter medicine and it doesn't necessarily really help them. or a supplement, I mean, and it doesn't necessarily really help them. But there are longer acting forms of melatonin, like an extended release form. So you don't necessarily need to reset your sleep cycle. You just need to help stay asleep. So that might be another option to look into.
Okay, very good. Thank you.
You're welcome.
Let's see. There was another question about melatonin that you referenced, and it wouldn't be a lunch with docs if we didn't bring up CBD. And it is relevant.
Yeah, it is, and I'm glad that you did. So we can add that to the list of what it is that I just mentioned. CBD, medical marijuana. I'm a licensed prescriber, and so sleep is one of the things that we do prescribe it for. And as far as if this is a topic that comes up, then I'm sure you've heard the same spiel from anybody that is talking about it. It is not something that we have a good handle on for specific recommendations. When a doctor is a prescriber, they're essentially just providing clearance. So when I'm prescribing medical marijuana for someone or suggesting CBD for someone with sleep fragmentation or sleep disturbance, I let them know honestly, like, this is a conversation that you have to have with whomever you're purchasing this from, because they're the ones that are going to tell you the combination, if it's medical marijuana, of THC to CBD, and the type of form that might be useful to use, whether it's an edible or an ingestible or an inhaled form, or a topical form, or whatever it might be. So I don't have expertise to say this type of medical marijuana is the one that is best for sleeping, but those are the questions to ask. But as far as generally speaking, can it be helpful for sleep? Absolutely.
Okay, very good. The next question is about dopamine agonists.
Mm-hmm.
Can you explain how dopamine agonists can cause some cognitive symptoms that are similar to PD-related cognitive symptoms?
Sure.
We're concerned about how long to continue this medication and the risks.
Sure. So if you're on a dopamine agonist, it is often dose related. So the higher you go with the medicine, the more symptoms you might experience. And remember how I said there are different receptors that dopamine works on? Well, dopamine agonists work on different receptors. Some of them work more on the D1 receptor. Some of them work more on the D3 receptor. Some of them work more on the D2 receptor. Depending on how your brain chemistry works, some of those receptors are more impacted by cognition than other receptors. So if, say, you just started the medication and you're noticing that it's having some improvement with your motor symptoms, but you're feeling a little groggy or a little slowed or medicine heady, and that's not passing. If you have stabilized on a dose and you've been taking the medicine for, a number of weeks, if not months, and that symptom is still there, then you're probably one of the people where whatever receptor it's working on is more impactful for cognition for you. And then you should come off of the medicine and see if the cognition improves. Now, if you come off of the medicine and the cognition is still the same, then it could have just been progression of Parkinson's disease cognitive concerns and nothing to do with the dopamine agonist. And if it was helping your motor symptoms, go back on it and then treat the cognition separately. But if the symptoms improve as you come down off the medicine, then either trying a different dopamine agonist or staying away from that class altogether and going, looking to another medicine that might help with motor symptoms. I know I'm not going to say that I remember which agonist as far as ropinirole or pramipexole works on which receptor, but I do know that Nupro, the patch, is primarily more a D3 receptor, which is why that one might have less of a cognitive impact, because those receptors have not been as implicated in cognitive side effects.
Okay, good. Okay, I have a tough question for you, Dr. Farmer. Okay, and this was sent to me privately. So this attendee says, I know my mind isn't what it is, and frankly, it's been depressing to learn about why it's not what it is. Why should we even talk about this? Should we talk about something more hopeful? What hope can you give me?
So actually, I would say there is a lot of hope to give to patients with Parkinson's disease. It is a degenerative condition. We can't erase that fact. It does have an impact on a lot of body symptoms. We can't erase that fact. But we have lots of ways to manage and treat it, more so than other people with other sorts of degenerative neurologic conditions do. And there is a lot of research that is being completed at the moment that is really focusing on disease progression, delaying disease progression, or disease modification for those that already have established disease. So the hope comes in the fact that we have a good understanding of the pathology of Parkinson's disease. We have a good understanding of the deficiencies that dopamine and the other chemicals in the brain cause. And now we are focusing more on being able not just to manage symptoms, but to also manage the ability to regulate and modulate the disease in some way, which is, these are not things that are pie in the sky. They're entering phase 3, phase 2, and phase 3 studies. So the brought to market or the clinical applications for them are coming quite soon. And that's just medications. We also know that there are a lot of therapies that are helpful in managing symptoms of Parkinson's disease. That whether it's the big and loud therapies or the Parkinson's wellness recovery therapies or a rock steady boxing, all of these things have an impact because everything is related, not just on one thing. So while it might be helping motor, it can also be helping mood, it can also be helping cognition and things like that. If you have, there's also a lot of patient advocacy groups that are available. And if you're feeling overwhelmed by it, and it is completely understandable that you are, if not all the time, then from time to time, then reach out to the advocacy groups and they can help put you in contact with support networks and things like that.
Very good. And thank you, Jim, for also writing that he finds that information is empowering, and he's always worried that when he can't recognize a face, it's because he's about to get Alzheimer's. So understanding the difference between Alzheimer's dementia and Parkinson's dementia has been empowering for him. So I think that if that, you know, at the very least, we have used our brains today. Your slides were excellent, and I think you delivered them in a way where, yes, if I would have just seen those slides on their own, I would have thought it was beyond me, but your explanations of all of them were so helpful. And I think it's always interesting to see, from a clinician's perspective, I think everyone knows their own perspective, but to kind of see the complexities, what you're looking at when you're sitting down with a patient. And yes, we talked about some other things that you can do, exercise, cognitive therapy, and I think even, what we did today, learning something new, asking questions, that has some, some benefit as well too, right, Dr. Farmer?
Absolutely, absolutely. And like I said, I cannot get over the 153 participants. I mean, that's just amazing. And kudos to you all for taking the time to seek out the information and get it in a way that is palatable for you. We don't want it to be frightening. We don't want it to be scary or overwhelming. So take snippets of what you've learned today. And if there are more questions that come up, then everybody at the Alliance knows how they can get in touch with me, and that's never a problem.
Wonderful. So we didn't get to all of the questions. Thank you all for sending those in. I'll mention a couple. There were some questions about biomarkers and research. We're going to have Dr. Chuck Adler from Mayo Clinic on next week on Friday, June 5th, and he's going to be going in depth about that. So check out our website, those of you who asked about those questions. There's been some questions about psychosis and hallucinations. We're going to have Dr. Dan Weintraub on Wednesday, June 17th. And that is going to be the focus of his presentation. So we can't squeeze it all in an hour. We try, but do take a look at our website. We have a packed June, at least one program a day to try to bring you, you know, these educational opportunities. And you know, speakers like Dr. Farmer are so generous to donate their time and their expertise. And that's just what we love to do, is to hook up people with information, with people who are wanting information. So thank you to both parties today. Thank you for joining us, Dr. Farmer. Thank
Absolutely.
you to everyone who tuned in for your excellent questions and attention. If anyone wants to refer to the recording, it'll be on our YouTube channel by the end of the day. And this might be a good one to rewatch and pause and take notes. Dr. Farmer did such a great job, squeezing so much in there. So that wraps us for today. Thank you. And we always like to have a little bit of virtual, digital, long distance eye contact. So if everyone wants to turn on their camera and put it in gallery view, and we can do the goodbye wave. So thank you. So good to see everyone. Thanks, Dr. Farmer.
Of course.
Bye, Mary. Bye, Yara. Bye, Shirley. Thanks so much, everyone. Have a great